Welcome to Be Time, everybody. I'm Beth Bierbauer, healthcare executive, author, and host of the Be Time podcast. Be Time is a podcast for individuals who want to invest in themselves and their careers through continuous learning. And each week on Be Time, I have the privilege of interviewing a seasoned executive, company founder, or other industry expert, and we talk about a lot of different business matters. You'll hear about individuals' personal as well as professional journeys. You'll get business insights, learn about emerging trends, and more. So whether you're with a large company or a small business, inside the healthcare industry or out, Be Time has something for you to help you stay on top of your game. So let's get started. Today, we are going to talk about episodes of care. When you think about an episode of care, think about looking across a condition or a treatment and pulling all the related transactions together, so that you can get a holistic view of what has taken place. Health plans like to look at episodes because it helps them really deeply understand the true cost of care. Providers like to look at episodes because it helps them better anticipate the needs of their patients. And this sounds like a good way to look at healthcare from my perspective. Unfortunately, the actual member experience doesn't have that holistic view. Each provider seems to operate in his or her own silo, and even the health plans don't do a good job of pulling it all together for the consumer. With us today is Duncan Reece, who is COO and co-founder of Cohere Health, which is a company whose mission is to enable the care journey that is right for the patient and do whatever it takes to arrive at that outcome quickly. You're going to learn how Cohere Health is breaking down barriers and also the other areas that they are really focused on to help improve that member experience. Now, Duncan's background is steeped in healthcare, and he has worked at such outstanding organizations including Health Dialog, Iora Health, and behavioral health company Mindstrong. So please join me in welcoming Duncan Reece to Be Time. Duncan, welcome to Be Time.
Thank you, Beth. Nice to be here.
Well, we are very, very glad to have you. So, Duncan, what I'd like to do is start with you maybe setting a little bit of context. What specific areas within the healthcare system have captured your attention? Would you share that with us? And also what some of the pain points are that you're trying to address?
Sure. Well, lots of areas capture my attention. But I think one relates to a story that I think would be helpful to start off with. It's a personal story of mine. It's a story of my father. So related to a back pain episode that he had. So my dad, at the time when he was struggling with his back, he was in his early 70s. He's a retired healthcare executive. He lives in the Boston area with my mom, who's a nurse practitioner. So very healthcare literate family. My dad had the burden of being a former Division I college hockey goalie. So he was used to living his adult life in pain. And so he knew how to manage that pain over his life. But for a couple of years ago, that pain took a turn for the worse. And it made him and my dad really nervous, or my mom really nervous, because they knew about the risks associated with back surgery and they were really scared. So my dad's journey started with spending time, Googling, talking to friends and family, and trying to understand what might be going on with his back and how he might be able to deal with it himself and see what his options were. That went on for a couple months, but ultimately the pain got worse and he had to deal with it. And so he then went in to go see his primary care physician, which basically started a journey of about 14 months of pretty unbearable pain, lots of time spent away from things he wanted to do in his life, and anguish and dealing with this episode. So to give you a sense of like the complexity of what my dad had to deal with it. And I don't think his story is very unique. I think folks who listen to this podcast, who have dealt with back pain or pain in general, probably have experienced similar things. So my dad went to the PCP. His PCP is wonderful. My dad thought the pain was in his hip. So the PCP referred him to a hip specialist. The hip surgeon very quickly recognized that it wasn't a hip issue, it was a back issue, because it's very common for people to mistake hip pain for back pain. And so the hip surgeon referred my dad to a spine specialist, a neurosurgeon. My dad, of course, was very nervous about this. So he went back to his primary care physician and asked him, how can we avoid surgery here? And so the PCP, taking sort of my dad's cue, said, well, maybe we can send you to pain and work through a pain protocol. And my dad was happy with that because it sort of got him away from the path of surgery. But there was no sort of rationale behind that. So then he was referred to a pain specialist, who then promptly recommended my dad, prior to going on any interventional pain therapy, to actually go see a physical therapist. And so that was a little disappointing for my father, because he did a lot of stretching and physical therapy like work. And sure enough, when he showed up at the physical therapist's office, he knew how to do more of the stretching than the physical therapist did. And so that wasn't very helpful. So that didn't work. So back on to the pain interventional program, which set up a series of injections. Meanwhile, time is going by, right? Because the time it takes to get at one of these appointments can take weeks or months. And so he gets set up on interventional pain, which means like injections into the back. The injections went into different parts of his back because his back condition was very unclear, in the sense that he had a lot of things going on from his time playing hockey. And so ultimately none of that worked. And finally he went back to his PCP, and they sort of realized, hey, we can't, this isn't working. We need to go to a different path. He talked to nurse practitioners who were associated with the pain specialist. He talked to nurse practitioners who were close to the neurosurgeons. And ultimately, he ended up with a consult to a great neurosurgeon who made the diagnosis that was ultimately the diagnosis of my dad, and the treatment plan, where my dad needed surgery and had surgery that had a great result. So today, my dad is in a great place. He is fully recovered, and he's starting to play golf and do all those wonderful things. But through this time, he went on this incredible journey of lack of clarity, incredible pain. He wasn't able to spend time with his grandchildren. He had to take pause on all the things that he wanted to do in his life in retirement with my mom. And that is all with the best of knowledge of the healthcare system and the best access to care, the best insurance possible. I think what's frustrating about this is it's not uncommon. And you think about the kind of access that someone like my dad had. You think about folks who don't have that access, it's even more troubling. There's also other issues that happen here. So the health insurance plan that's trying to help my dad isn't able to, because they're not able to understand what's happening 90 days post-claim and what's happening in his journey. Also, what a lot of people don't understand is the providers, the doctors, the nurses, the nurse practitioners who are involved in my dad's care also are struggling through a lot of complexity through this. One, because the diagnosis is complicated. Two, because back pain is difficult to deal with. But three, there's an incredible amount of complexity that is put on physician practices in trying to get different kinds of care that happens to be expensive, specifically prior authorizations. So for someone like my dad, who had MRIs, CAT scans, physical therapy, epidural injections, surgery, post-surgical home care, durable medical equipment, all of those things require prior authorization from the insurance company. And that is real work that provider practices have to put in. It was all approved because it was all in the evidence base, but ultimately it was dozens and dozens of complex administrative processes that probably could have been orchestrated in a different kind of way. That time could have been if folks had that time back.
That's a really disheartening story. And you're right. Your dad had access. He was knowledgeable of the healthcare system. Imagine the average consumer that doesn't know healthcare, right? And maybe doesn't necessarily know where to turn. So tell me how Cohere Health is addressing these pain points that your dad encountered.
Yeah. So I think the interesting thing is the opportunity that we see at Cohere is to actually, there are lots of wonderful companies trying to help with patient navigation. They're trying to advance practice models and care. But sometimes those initiatives are felt like additive to the healthcare system, which puts more work on top of doctors and nurses and other clinicians. Our insight is we see the opportunity to help folks like my dad and my mom by actually going into these complex administrative processes, like for example, the prior authorization process, make it radically simpler so that the time that could be otherwise used in those administrative processes could be used to help with care coordination. And then the money spent on those processes could be used in different kinds of ways. And then the health insurance company could be a better partner to my dad, to his doctors, and to those folks who are involved in my dad's care. So we see the opportunity to basically go into these complex revenue cycle elements of the healthcare system, make that radically simpler, and then be a partner to the folks who matter, and those folks are my dad, the health plan, and obviously the doctors who are caring for my dad.
So does it look like a care pathway with a single authorization? Oftentimes at the health plan, we would try to talk about super auth.
Yeah.
How does it manifest itself?
Well, I think super auth is a really interesting concept and it's appealing to think about. Say, hey, why can't I just buy a whole bundle of things at once? The reality is, and in some procedures that makes sense, but like with back pain, the first authorization that any provider had relative to my dad's back episode was an MRI. An MRI is a diagnostic test to figure out what the diagnosis is, and then to help build the right treatment plan. And so it's inappropriate to sort of auth a whole bunch of things. And so we think about it very much from a care pathway perspective, which is the way doctors and health systems have thought for decades. And so ultimately, we engineer the prior authorization process to resemble the way clinical decision support works in an electronic medical record, so that it's intuitive for the physician and his practice to get the needed services for my dad. And then that allows us to more easily approve things instantly. So the way to think about it is we can approve things, and oftentimes up to 90% in real time, versus some health plans who have old clunky systems that might never be approved in real time because they're all based on fax and phone calls.
Yeah, the fax. The fax machine is something in the healthcare system that needs to go away.
That's
So
right.
was it because of what you experienced with your father? Was that your defining moment where you said, I've got to go do something about this?
It wasn't because of my dad's episode. I think I happened to be a part in a journey in my life. I had the opportunity to work at wonderful places that thought about shared decision making before people associated that with value-based care. I had the opportunity to work in a company called Iora Health that was an actual provider group. And I was effectively an administrator, an operations business person. And what I realized in my career there was that my job as a non-clinician, I'm not a doctor, I'm not a nurse, I don't take care of patients myself, but if I'm in that kind of place, my job has to be, and I sort of believe anybody in healthcare who's not a clinician or patient facing in some way, your job has to be about making it easier for the right kind of care to happen. And so that theme is very important to me as a person. And then after that experience at Iora, I had a chance to work at a behavioral health technology firm that struggled to get engagement of its wonderful services for folks with things like severe depression, that kind of thing, which by the way, my dad experienced some of those issues too. There was no mechanism to plug in the patient into our program. So all these things were bubbling up in my career. I was looking for something different. And it happened to be the case at the time. There were some really forward-thinking folks in the insurance business, doctors, and venture capitalists who came up with the idea, which is now Cohere. And they were looking for somebody to take on, to join the company and to kind of get it off the ground. And so for me, it was a sort of right time, right place. And certainly my dad's experience made it very, very personal for me, because I feel very strongly that if Cohere were around for my dad, he would have been better off. He would have, that 14-month experience would have been maybe 4 or 5, 6 months, right? Something less. And he would have had less pain, and he would have had access to better advice, rather than, him calling his son for random requests. And I'm not a clinician, obviously. So it was a sort of nice confluence of events that got Cohere started.
So why don't we dive a little bit deeper on each of Cohere's solutions? I think you have 3 major solutions. So maybe you can share what they are with our audience and help them understand more.
Yeah. So at Cohere, we think about 3 main solutions. The sort of biggest area, the first area we're starting to tackle, we call digital prior auth. And it relates back to the complexity I talked about with my dad's experience, where you have this incredible amount of administrative complexity that accrues to the physician, that accrues to the health plan, and that ultimately is, the price is paid by the patient in terms of delayed access to care. And the technology, I encourage anyone to go ask your doctor, what their process is for managing the different prior auths that they experience by different insurance companies. And I bet some of them will take you to the back office to a scheduler, and they'll show you a spreadsheet that's several pages long that has 40, 50, 60, 70, 80 different processes. And that's sort of the state of prior authorization. So we think of this opportunity as a means to basically, for the health plan, help better coordinate care and deliver higher quality access to patients by making the prior authorization process more streamlined, in line with the medical science. So we have a partnership with the American Academy of Orthopedic Surgeons, and then built on very good modern technology. So why are we using fax, right? Why can't we use some of the best software, and why can't we plug into electronic medical records? And so what that allows us to do is better support the patient, better support the doctor, and obviously better support the insurance company, so that patients get care much more quickly. So if we're auto approving 90% of requests in real time, that means the patient can be scheduled that day for something, right? Versus what typically happens is 14 days. And then, we see 92% of our authorizations coming in via software and technology versus, somewhere between 0 and 70%, depending on the service. And so that digital layer, and when you organize it around an episode, is very powerful, because it means you can do many other things to help patients, doctors, and health insurance companies. That leads into our second core solution, which we call sort of utilization management, care management integration. And our belief is these two things are the same in the sense that why do you have these two different named processes to take care of patients? You should use the data that you gather in the utilization management process to better connect patients to programs that are valuable to them. So, I know you had a guest on your podcast from Able2. It would have been great for my dad to have access to Able2, right? It would have been great for my dad to have access to a second opinion service. He had to do that all himself. And because prior authorizations happen in real time, because we're capturing them in a digital way, because we have partnerships with different kinds of musculoskeletal and other programs, and we can connect to what the insurance company does, we can then activate that. So we're really excited about that opportunity. And then lastly, we have a solution around value-based care, which is effectively, again, the similar theme is if you're in the data layer of these episodic authorizations and you think about it from a value-based way, you can be much more helpful to the specialist. You can be much more helpful to the primary care physician. You can be much more helpful to the patient. And so we actually engage each of those and help make them aware of each of their perspectives to better activate their care plans. So, for example, we help specialists take on bundled payment contracts, and we help specialists perform more strongly in those based on what the evidence base says. And we help primary care physicians, like some of the best PCPs in the country, better understand what's going on when their patients are at the specialist office. And we can do that because we are that digital layer.
So you're able to, on the value-based care side, help a specialist understand how to get into value-based care by helping them understand what they should expect and ask for, and then monitor their performance. Is that correct?
Yeah, I mean, if you think about it, a specialist, right? The shift to value-based care has been frightening when you think about folks being used to a fee-for-service model. You see payment decreasing, and then you hear about these bundled payment programs or different kinds of value-based programs. Some of them weren't always designed effectively, and so folks actually, perform worse financially. And so the specialists are really fearful of signing up for something that's going to hurt their business, right? When they're trying to do the right thing for patients. So a lot of what we can do is help give them the data, help give them the scalable processes via technology that allow them to feel confident that their staff are following the surgeon's desired care plan and executing it in a way that will deliver strong financial results for the specialists in line with the patient's needs. And so that's a big feature. Similarly, you think about all these globally capitated primary care physician groups like my alma mater, Iora, that are getting into direct contracting. How can they understand what's happening in the specialist community with their patients? Like they don't have a mechanism to do utilization management. They don't have, right now we're not installed with GPS devices, embedded into our skin. And so we can provide the ability for PCPs to better connect with their patients in that way. And also, importantly, specialists and PCPs to work together, because we believe utilization management should be about doctors talking to doctors about the right care for their patients. Historically, that's been too hard. Back in the day, you could do it when your primary care physician was rounding at the hospital. That just doesn't happen anymore. So we believe we provide the opportunity to use technology to allow those connections to happen.
I want to comment on what you talked about with utilization management and care management, because oftentimes there's such a disconnect there where you have a care manager that's working with the patient, and then the patient is following that path, and the utilization management people call and say, no. And you're sitting there saying, well, wait a minute, I did everything I was supposed to do. I'm working with a care manager from the health plan, but now this side of the health plan is telling me, no, I can't have that service, which makes no sense.
Yeah, and I have to remember that it's not malintent by the folks who are doing that. Like what's happening is each of these programs have defined rules and processes and guidelines. Sometimes, like at an insurance company, you might actually have third-party vendors who do different pieces of that puzzle. So even if you think about my dad's back pain journey, a typical insurance plan might have a different vendor for MRI management, a different vendor for physical therapy management, a different vendor for surgical management. They might do it in-house for inpatient surgery, in-house for DME, a different vendor for SNF management and home health. And so it's impossible, right, to get everybody on the same page unless you have sophisticated ways of putting the data together that allow for folks to make the right decision. So part of what we're trying to do is help be that connectivity and connective tissue that allows for evidence-based treatment plans to happen that are right for the patient, that are supportive of the doctor's care plan, right? Like that's, at the end of the day, that's what should happen.
Well, that leads me to the next question is, why isn't a health plan connecting the various silos within its organization or with its third-party vendors itself? They can't sort of step back and say, this is what needs to be done, or it's too large of an investment. Why do they need to come to a third party to help them with that?
It's an incredibly complex web of technology, lack of tech. Actually, oftentimes it's a lack of technology problem. The reality is a lot of insurance companies are built up on a series of acquisitions, different claim systems that might be very old. You get a portal from over here, you use one vendor over here. And I would say all the health plans are making significant investments into their information technology systems to be able to do that. But in the meantime, they need better connection. And there's some interesting companies who are trying to support this process by just, like the prior authorization process, for example, by just connecting to EMRs. But the reality is more data into a sort of broken system that isn't able to connect the dots internally within a health plan. All it does is actually add an additional administrative expense to the health plan. So the health plan has like incredible numbers of people whose job is to just troubleshoot all the issues that happen across all these different systems and vendors that generally don't talk. And in some cases, there are federal and state and other guidelines, requirements that make it even harder. So it's really complex, which is why we think there's an opportunity for somebody like us to simplify it and help.
So we talked a little bit about value-based care.
Yeah.
I'd like your perspective on value-based care, just from an industry view. Think we're going fast enough? Think we need to go faster? What's your viewpoint?
Yeah, I mean, I think I'm biased based on my background, but I think value-based care is a necessary requirement for our future sustainability in healthcare. I think obviously it starts with payment, but payment is not sufficient. It's a starting point. I think you look at what happened with COVID, and those folks who were in value-based arrangements generally perform better than those who weren't. So I think it's incredibly important to continue to make the investments to push the market along. I think the challenge I see is sometimes folks try to take, as you know, Beth, there's a huge spectrum of folks in value, right? You've got the Oak Street Healths of the world who are, and the Ioras and the ChenMeds who are way ahead from a primary care perspective. And you can't apply that model to a traditional health system owned primary care practice. But guess what? That practice and the physicians and others in that practice also want to practice in a value-based way. So what we have to do, in my belief, whether it's a primary care physician or a specialist or anyone else, we have to move aggressively to value, but we have to be in a position to move people along in the way that's right for their situation. Otherwise, it sets different kinds of groups up for failure. And we just owe it to patients to get it right. So I believe very strongly we need to move fast, but we need to be thoughtful and recognize that the systems and technologies and protocols we build have to recognize that there is that spectrum and we need to move everyone along in a way that makes sense.
When you think about the solutions you have, it sounds like you're selling both to health plans as well as to providers. Can you give us some sense of relationships you have? Are you working with 5 different health plans now, or 1 or 2 of the majors?
Yeah, our biggest relationship by far is with a health plan named Humana, and who you know very well. And I think obviously very forward-thinking organization that recognize the opportunity to to help kind of make this all happen. I think if we were a traditional startup trying to break into this space, it would be very difficult to do so without willing and accommodating partners who recognize, hey, the answer here is interoperability. The answer is a payer agnostic solution. The answer is technology. And the answer is, hey, an organization that is trusted by physicians, and we need to, activate a Cohere-like example. And so I think Humana obviously has been we're in 12 states with them, over 2.5 million members, all lines of business. We're doing something like 60, 70,000 authorizations a month, in terms of volume, and doing so at producing really great results that provider practices love, or at least don't hate is probably the better word. We're talking to many other health plans, regional plans, some of the startup plans who are really trying to differentiate around member experience and physician and provider experience, as well as national plans who recognize the opportunity to activate technology in a different kind of way and radically decrease the administrative expenses that their organization has in some of these clunky processes.
Well, clearly you're bringing some deep expertise to the table that it's difficult for the health plans to have. And you're absolutely right. Most health plans, at least when you look at the major ones, have been around for a long time, and their systems are just complicated, is saying it nicely. So the ability to really be able to come in and navigate that morass, if you will, of systems and connections. And I think you said something really important. It's about connecting the dots as well, and making sure that what happens on the left is connected with what happens on the right, because that's where the consumer really gets stuck, when the left hand doesn't know what the right hand's doing. And in my example, they've done everything that they're supposed to do. As you look out, Duncan, on the horizon, are you eyeing other pain points to focus on, or is there just so much more to do? You're focusing on 3 really big areas.
Yeah, well, it's funny. There was a JAMA article that was published in 2019 that talked about the waste in healthcare, kind of validating some of the early research from way back that said 30% of the health system is waste. And they found they sort of quantified, I think, the administrative waste is something like $300 billion. And so there's a lot to do there, Beth. But I think I think so we see a lot of opportunity there. I think what is going to be interesting around what Cohere does is thinking about scaling nationwide. So this is not just something that happens in a pocket of the country. You're going to hear us talk about engaging patients directly. So you and I, we do shopping on Amazon, and we're very used to understanding, where exactly our gifts, our boxes, the things we buy are in terms of the process of being shipped across the country to our home. Why is that not the case for patients? And so you're going to hear a lot about us from that perspective. You're going to hear a lot more from us around these value-based care elements, where we're connecting PCPs and specialists together to deliver the results. Because again, we don't think that's the role of the insurance company or some third party. We think it's the role of activating those connections that should happen naturally. And I think the other big area is really novel and differentiated uses of electronic medical records. I think there's a lot of buzz in the industry about, let's get into the EMR. But what a lot of organizations don't understand is, if you do that wrong, you actually put more work onto the doctor, which we think is abhorrent. We need to find ways to get the information that's in clinical documentation in a way that makes it easier for physicians, not harder. So we're very focused on that.
I love the fact that you are focusing in the future on engaging patients, because many individuals really take it upon themselves, because they know how complex the healthcare system is, to make sure that they keep meticulous records. So they know where they've been, they know what the doctor have said. And sometimes it is really as simple as if somebody from the health plan or the provider's office would just pick up the phone and talk to the patient or the caregiver that's helping that patient. you could really cut through a lot of red tape. But that's where I often see it falling down. Nope, this is my silo. I'm looking at what's in front of me. I'm not going to bring the patient into the loop. And if you would do that, problem solved. So kudos to you for really saying, wait a minute, the patient should absolutely be involved and should absolutely have some input there. And they can be the glue to really help hold things together.
I mean, ultimately they have to be, right? They are today. So my dad, it was up to him and my mom, right? So, and the reality is, if Cohere were around, we could have recognized at the point of that MRI that my dad got at his PCP's office, we would know that the different pathways that were available to him would have gone in only 2 or 3 or 4 different directions. And we could have explained all that to him and given him and helped him understand his options, help him understand the kinds of questions he should ask, and help him figure out how he should be working with different providers. Even that alone would have been a game changer for my father. And so we think it's the biggest untapped opportunity. Yes, we need to take work off the hands of the patient, but in the near term, in this healthcare system, we have to help be a better partner to patients for sure.
And I want to tie into one other thing that you said, Duncan, which I think is important. Dr. Paul Grundy was on the show a few episodes back, and he recommended a book, The Healing of America by, I think it's T.R. Reid. And when I read that book, Reid went around to different countries. He had a shoulder problem. And in each country, he was going through their health system about his shoulder problem. But one of the biggest things that I recognized was in many of the countries, the costs were lower simply because there wasn't any paperwork. There were no prior authorizations. The doctor submitted the claim got paid. And oftentimes we forget that when we put all this administrative expense, we think, oh, look how much money we're saving here from a health plan perspective. But what we don't understand is how much burden then we're putting on the providers, which causes them to want to continue to increase their costs. So good for you for getting after that administrative expense, because I really believe that is something we don't focus on nearly as much as we need to.
Yeah, and as Dr. Grundy pointed out, it ultimately gets to the patient, right? So the complexity drives lack of access, drives delays, drives confusion between organizations into what the patient should receive. So, I don't think it's a novel concept, and it's something like $300 billion. So there's a lot of low hanging fruit, but it is important that we start to recognize that. If you think about this COVID world, where all the physicians, nurses, and other caregivers who put their lives at risk to help to do their job, it's just incoherent to me that we would not try to find ways to make it easier for those folks to do what they were passionate about to do in the beginning, why they spent so much time and money in school to do this work. So we have a big role to step up across U.S. healthcare today.
For sure. Lots of opportunity. Well, Duncan, we are learners on this podcast, so we like to ask our guests, what books are they either currently reading or what might have inspired them, and what is on your podcast playlist?
It's interesting. And over the COVID time, I went from being someone who was on the road all the time to someone who's at home all the time. And you'd think I would read a lot more. And that is true, although I've shifted my reading to read with my kids. So I have an 11-year-old boy and an 8-year-old boy. And every night I read with each of them. So my reading has moved into more interesting levels. The Trials of Apollo is a sort of a Greek god moved into modern times. Interesting book that I'm reading with my 11-year-old, and then I'm going back to the old Roald Dahl stuff with my 8-year-old. So
how fun!
So fun stuff. I do need to get back into some more serious stuff soon, but it's been wonderful to spend time with my kids. And then on the podcast side, similar theme where we spend a lot of time in the car trying to get out and drive around, and with my boys and my wife, we've been listening to a lot of Guy Raz, How I Built This. And it's just fascinating to see, now my 11-year-old will talk about investors and profitable and all these kinds of things, which is really fun. I didn't understand those concepts until I got out of business school. So that's been fun.
I have to share with you, I just did some unpacking in a house move, and I found Laura Ingalls Wilder's books.
Nice.
Which I used to read as a child over and over and over. I would take those out of the library, and I put them on my bookshelf, and I'm going to read them one more time before I donate them to somebody else who can enjoy them. So I appreciate that you are reading Roald Dahl with your kids. Great author.
Brings back good memories. Yes.
Yeah, for sure. For sure. Well, Duncan, thank you so much for being with us on the podcast. You and the team at Cohere are really doing some great work to try to not only simplify the process, but ensure that individuals get on the right care path so that they can get easier and earlier identification of problems and then get to treatment sooner. So thank you so much for being here.
Thanks, Beth. Really appreciated the time.
And for our listeners, that's it for another episode of Be Time, and we will be back in a week. Thank you.